Now we're getting to the good stuff. So if we classify skin cancer, we usually divide it up into non-melanoma skin cancer and melanoma skin cancer. So melanoma skin cancer, most people will know about. You're looking for a dark mole that's changing or any new type of dark spot that's come out on the body. Anything with, if we talk about the ABCDs, you're talking about an asymmetrical lesion, something with an irregular border, anything larger than 6 millimeters or the size of your pinky nail, anything with different colors, anything that's rapidly enlarging, anything that's bleeding or becoming symptomatic. Although a lot of melanomas are asymptomatic. If it's on your back, you might not even know that it's there. So those are melanoma skin cancers. There is a group of non-pigmented melanomas that you call amelanotic melanomas, and those are quickly arising pinkish or skin-colored bumps or vascular types of lesions. So there are anomalies on this list. And then also under melanomas fall acral melanoma. So those are melanomas that you get on the palms or the soles, as well as on the nails. And those are usually pigmented, and they often present quite late because they're not in sun-exposed areas and people don't really know to look for them there. But if we're talking about melanoma as a group, that is our most aggressive type of skin cancer. That's the type that usually metastasizes or spreads very quickly. If we look at something that is picked up early, we want to pick it up at the time when it's less than 0.8 of a millimeter.
Wow.
So less than a millimeter thick. We're talking about a small lesion, 2 or 3 millimeters in size. So that could be something that looks like a freckle on your skin. And that's why you need skin check for that type of specific pigmented lesions, because screening picks up early lesions. And now within the last few decades, we've seen dermoscopy come into our field of dermatology, where we look with properly designed handpieces that have very highly specialized lenses, as well as using polarized and non-polarized light so that we can actually see into the upper layers of the epidermis. And we're looking for specific patterns. So as a dermatologist, we've had 4 years of training of looking at these lesions day in and day out, and we know what to look for in terms of picking up early changes in these moles. Interestingly, for melanoma, only about 20% of melanomas come from pre-existing moles. So moles that become dysplastic, that change, and we can say how much of those lesions will eventually become melanoma. We don't have an exact number, but we know there is a higher risk. There's lots of publications on that. So we definitely look for those things and we biopsy them. And then 80%, actually come from new. Come from new, right? So de novo melanomas.
It's something that you didn't see last year on your screen, and suddenly there's this new lesion.
So the cutoff, as a rule, we use 35. So under the age of 35, you're allowed to get new moles. They're allowed to change a little bit. Above 35, I know it's a cutoff, but that's what we use. And you're not allowed to get any new or dark spots on the body. If you find anything new, it needs to be checked. That is a skin check, And then if we move on to non-melanoma skin cancer, the two groups in there is squamous cell cancer and basal cell cancer. And those are very common on our lighter skinned individuals. It is definitely also from chronic sun exposure. Squamous cell cancers, that falls under a classic type of cancer. So you have a precursor lesion, an in situ lesion, meaning it fills the epidermis, and then you get invasive SCC. I usually tell my patients, if you can wish for a type of skin cancer, then you rather take SCC or BCC, and definitely not melanoma. So squamous cell cancers, they can metastasize and they can infiltrate, meaning they grow down into the deeper tissues. But if you catch them early, again, because they have those precursor lesions, if you catch them early, you cut them out and they're gone. So what you're looking for there is a reddish or pinkish kind of thing that even starts like a pimple or like an eczematous patch on the face, often more in men than in women because they've had more sun on the scalp and the ears. But typically forehead, scalp, the bald scalp, ears, and neck and chest. Even on the hands and the forearms, and we call them these gritty papules. So when you touch them, they're a little bit rough on the surface. It's something typical that you pick off the scale and it comes back. So every time it will be back. The patient will say, "Doctor, I scratch off the scab," and it will come back. And now when that lesion goes a little bit deeper, we're getting to that in situ phase. Often patients will say, well, now it's actually becoming a little bit tender or itchy. And that just gives us the idea that it's gone through the epidermis. We're reaching the tip of the nerves that come through the dermis. And that's usually, then I'll say to the patient, well, actually, this one we need to biopsy. Most of those early lesions you can treat with freezing, so cryotherapy, and you follow that patient up regularly. And that's your typical type of patient that you'll see 2 or 3 times a year, and just make sure you stay on top of things. Then with your basal cell cancer, that is typically a little shiny papule, again pinkish or skin colored. It will just start on its own, and it doesn't have any precursor lesion. So once it's there, it's there. It's luckily slow growing, and it's usually not invasive. It is just quite destructive. So if you leave it, it often likes areas like the nose, the ears, on the temples, next to the eyes. So you can imagine if you leave it for long enough, it will eventually grow down into the deeper tissues, and it will invade into the cartilage or down into bone, and it's destructive. So you end up having to cut out a lot. So again, for those, you want to pick them up early, you want to cut them out completely, and then you have a really good prognosis for those types of patients.